Next up, we have Dr. Elan Ziv. He is the CEO and Medical Director of Contipi Medical. They are the creators of the TP device, or Poise, which is a solution for stress incontinence, and they have prolapse solutions as well, so supporting women with pelvic floor disorders the world over. He currently holds 19 patents and over 100 patent applications, so beat that. And he'll be speaking to us about the new era in management for pelvic floor dysfunctions in women. Welcome, Elan.
So thanks very much for hosting me. Good evening, good morning, everybody. My name is Elan Ziv, and I am a urogynecologist from Israel. I'm also CEO of Contipi Medical, which I'll discuss a little bit later. The topic of the meeting today is the upcoming new era in the management of pelvic floor dysfunction in women, the shift of control into the hands of women. Before we start, let's talk about pelvic floor dysfunction, what it is. This is a set of disorders related to the woman's pelvic floor, the various organs in the pelvis, and the pelvic support system. We've got 6 different dysfunctions, but 3 of them are very well known. The one is urinary incontinence, the second is pelvic organ prolapse, and the third is fecal incontinence. PFDs altogether affect about 50%, or even over 50% of the women worldwide, with huge clinical and financial burden on patients and on medical system. And I'm talking about an annual expenditure of over $100 billion per year. There's also an alarming point here, which is the lack of innovation in the pelvic floor arena. On the left side, you can see the way it works in the stress urinary incontinence arena. The last surgical innovations was in 1996. Most of the non-surgical innovations came into the market in the 1980s. And the last one to appear in the market was ours, an impressive device, which we sold to Kimberly-Clark, which came into the market by 2015. There's some more devices getting to the market lately. When we talk about pelvic organ prolapse, this is a completely different situation. The last surgical innovation was in 2002, but these are the meshes. And as some of you may know, the meshes are not allowed to be used at all in most countries around the world. When we talk about the last non-surgical innovation, that happens in 1996. And then I'm referring to pessaries. I'll share what pessaries are in a minute, just ahead of time. Pessaries are inserts that are inserted into the vagina that may be made of plastic, PVCs, silicones, and others. So in 1996, a solid ring pessary, which I can even show the screen, it looks like that, and I can just show you if you try and squeeze that, it requires about 5 kilos to do that. So that solid ring pessary transformed into a foldable ring pessary. It's something that looks like that. You may fold it when you insert it, but you cannot fold it when you take it out. I'll explain in a minute. In other words, for the last 25 years, there's been no innovations in this arena. Just back one point about the urinary incontinence device. We developed the Impressa device, which was later acquired by Kimberly-Clark. It's already on shelves. And following the closure of the deal with Kimberly, we moved forward to develop our other devices. And the one that I want to show you today is the Provade device, which is for the non-surgical management of pelvic organ prolapse, or POP, in women. Just so that we're all on the same page again, this is a quality of life problem, affecting about 50% of the women above the age of 30, expected to rise about 1% annually. Currently, in the United States, we talk about 57 million women with some form of POP. Only about 3.5 million of them approach the doctors and come with a question of what do I do with this, how do I deal with this, how important this is. Just so that we all, again, see what it is, this is an example of a normal feminine pelvis. In the front here, you can see the bladder, you can see the vagina behind the bladder, and the uterus overriding the bladder, and then comes the bowel. In the case of quite severe prolapse, you can see the uterus, which is already outside the body, dragging with it the bladder here in front, and the bowel at the back. Obviously, this is a quality of life problem. As for possible treatments of prolapse, we can obviously talk about surgery. Everybody knows the word surgery here, but we may expect about 30% recurrence rate or failure when we use native tissues, and the meshes are not allowed to be used anymore. So the rate of surgery goes down. We always say less than 20, but to be right in percent, we talk about 8% or 10%. So 90 or 80% of the women around the world do not need any surgical procedure, but they're looking for non-surgical procedure. And what we have in the market today are the pessaries. I mentioned earlier that pessaries are inserts that are inserted into the vagina. They're made of silicone or plastic. Some of them are very hard, some of them are really intimidating and very large. This is an example of 9 different pessaries, 9 different shapes. We've got about 120 of them. The most widely used, in about 80% of the cases, is the ring pessary. So when we started working on a new device here, we started to take the ring pessary, try and take its upside, which is an excellent work in elevating the prolapsed organ, and take away all the downsides. So what we have today, this is what we call the ring pessary endless cycle. When a woman finds herself with a prolapse, she comes to the doctor. The gynecologist inserts a reusable only device, because all pessaries today are reusable only. The way it is done is, if you can see the screen now, the device is squeezed and inserted into the vagina, which goes together with discomfort and sometimes even pain. Then the device remains in the vagina for 3 months. She comes back to the doctor now takes the device out. However, since now there's no ability to insert a forehand and just squeeze the device to take it out, the device is actually pulled out in the same dimensions. And you can see the dimensions of the pessaries are somewhere between 60 to 110 millimeters, which is 2.5 to 4.5 inches. This obviously goes together with discomfort and pain. Then the device is cleaned by the doctor and reinserted for another 3 months. And this goes on and on and on for years. And I can tell you that I have patients who come to me for 20 years, every 3 months, to take care of the device. Altogether, what we have here is a device which works well in alleviating the prolapse, but goes together with much discomfort, sometimes pain, being a reusable only device, very long usage periods, which go together with a high rate of adverse events, dependency upon the endless clinic visits, nobody likes it. And there's one more thing, and that's sexual life. Because in most cases, the devices just block the vagina, and women with pessaries, if this is a pessary that she cannot remove by herself, and this is exactly that with the ring pessary, so intercourse is impossible or hampered. So we decided to move into developing a device like this in a different way. Certainly not the devices that we can see on the right side of the screen, which are large and intimidating and intrusive, but this is our Provade device. As you can see, it very much resembles the menstrual tampon in the shape. It's only 24 millimeters in diameter. Now, I wanted to bring a video animation to show this device, but since it's very hard to go over the internet, so I just brought some snapshots. The device comes ready for use within the applicator, which you can see in purple, and it comes sealed within a wrapper. You take it out of the wrapper, the same way you take a menstrual tampon, and you insert it into the vagina that way. And once it is inserted, you press the plunger, just the same way you press the plunger in a menstrual tampon. That deploys the device, which has been, as you could have seen earlier, very slender. Over here, it deploys the device to become a full-size ring, and then the device and the applicator separate, and the applicator comes out, leaving inside the deployed device, which is a ring, and the string for further removal of the device. And the applicator is taken out. Now, the device may remain there for up to 7 days or until the woman wants otherwise. She just pulls the string, the device shrinks back into tiny dimensions, which mean 24 millimeters, and then slides out of the vagina for disposal. This is certainly a disruptive innovation, which is so much different from what we have in the market today. By that, we empower women. Women are given the ability to take control over their medical problem. And as you can see, we emphasize the word medical problem because this is a real medical problem, not that she's sick, but she has a condition. By saying the word empower, it might be physical. Obviously, we dramatically reduce or even alleviate the discomfort and pain. We reduce the need to self-touch, the disgust, and the reduced body image. We reduced complications associated with available reusable facilities such as erosions and infections, and we allow for normal conduct of life without the dependency on the clinic. This is the last slide, which is most important. Actually, we bring with this device and all our other devices 2 huge social messages. The one is the shift of control. Control of POP moves into the hands of the woman rather than the hands of the doctor. And the second, which is even more important, is freedom to decide. The user decides when, where, and if to use the device. She may decide, for instance, not to use the device during the weekends or on Tuesday. The user may decide when to remove the device. And one important point for us is what we call the emergent or urgent removal, let's say for intercourse. In other words, the wish for POP alleviation is no longer a barrier to sexual activity. And this is where I say thank you very much for listening, Jess. And I'll answer the question at the end. Thank you.
Thank you so much, Elan. That was fascinating. And as a former LV alumna, I'm always fascinated by pelvic floor disorders. So I'm looking forward to talking to you about that later.